Hello viewers, I am Dr. Robiul. I work as a lecturer in pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is infective endocarditis part 2. In the previous part of this series, we had defined infective endocarditis and talked about the clinical classification, etiology, and pathogenesis of this disease. In this video, we will finish our discussion by talking about the morphology, clinical features, diagnosis, and management of this disease. Okay, so a lot of topics, so let's begin. We will start our discussion by talking about the morphology of infective endocarditis. Now always remember the classic morphologic feature in infective endocarditis is the presence of vegetations on the heart valve. Less commonly, vegetations may also occur on the mural endocardium as well. And we have already discussed what do we mean by heart valve and what do we mean by mural endocardium in the previous video of this series. So now you may be asking me, Dr. Robiul, which heart valves will be commonly involved in infective endocarditis? Now always remember the heart valves that are located on the left side of the heart, they are more commonly involved in infective endocarditis. And the most frequently involved heart valve is the mitral valve. For example, in this image you can see that this is a very diagrammatic image of a cross section of a heart. This is the left atrium of the heart. This is the left ventricle of the heart, and between the left atrium and left ventricle there is the mitral valve, and this mitral valve is most frequently involved in case of infective endocarditis. It is followed in descending frequency by the aortic valve, simultaneous involvement of mitral and aortic valve, and very rarely valves of the right side of the heart can also be involved. And always remember that in case of intravenous drug abusers, the valves of the right side of the heart are involved in infective endocarditis. Now, these vegetations can be single or multiple in number. They can involve one heart valve or more than one, and they will appear as large, irregular, friable, bulky masses on the heart valves. Now always remember, when these vegetations are occurring on atrioventricular heart valves, for example on mitral valve, they most commonly tend to occur on the atrial surface of these valves. And when these vegetations are occurring on semilunar valves, for example on the aortic valve, they tend to occur on the ventricular surface of semilunar valves. So always keep that thing in your mind, that when we are talking about the atrioventricular heart valve, the vegetations of infective endocarditis will most commonly tend to occur on the atrial surface. However, when we are talking about the semilunar valves, we will see vegetation on the ventricular surface of those heart valves. The vegetations of infective endocarditis will have some distinguished features that can help us in separating them from the vegetations that are seen in other major forms of endocarditis. Now always remember, the vegetations of infective endocarditis will appear as large, irregular, bulky, friable masses on the cusps or leaflets of the heart valve, and they can also extend on the chordae tendineae. Now you may be asking me, Dr. Robiul, what is chordae tendineae? Now always remember, these are cord-like tendons that connect the cusp or leaflet of the heart valve with papillary muscle. For example, in this image you can see that I have drawn a papillary muscle. Obviously there are more than one papillary muscles inside the heart, but to keep this image simple I am showing only one. So suppose this is a papillary muscle, and these are the leaflets of heart valve, and notice these cord-like tendons that are connecting the valve leaflet with the papillary muscle. These are known as chordae tendineae, and you can also see that in this image we have also drawn them in an enlarged manner. So this is the leaflet or cusp of a valve, and this is the papillary muscle, and these cord-like structure that are connecting the leaflet of the heart valve with the papillary muscle, they are known as chordae tendineae. And as you can see in this image, the yellow colored mass is denoting the vegetation of infective endocarditis, and you can see that here it has spread or extended on the chordae tendineae as well. Now you may be asking me, Dr. Robiul, what is the function of chordae tendineae? Why do we need them in our heart valves? Now always remember, the function of chordae tendineae is to prevent the prolapse of the valve leaflet that can happen during ventricular contraction if they were not present. Now let me explain. So always remember, the opening and closing of the heart valves are dependent on pressure gradient. Okay, so they just open and close depending on the pressure inside the chamber. So during the contraction phase of the ventricle, what will happen? The ventricular wall will begin to contract, and that will increase intraventricular pressure, right? So when pressure is high in this chamber, these valves naturally will tend to prolapse towards the atrial chamber, right? And that thing is prevented by these chordae tendineae. So they will act as anchor, and they will prevent these valve leaflets from bulging or protruding or prolapsing into the atrial chamber when the ventricles are contracting and when the intraventricular pressure is high. So that is the role of chordae tendineae, and as we are seeing here in infective endocarditis, the vegetations may also extend on the chordae tendineae as well. And one additional information that is nice to know is that the chordae tendineae and the papillary muscle, they are together also sometimes called the subvalvular apparatus. So that is also an important thing to know for your examination. Now always remember, the vegetations of acute infective endocarditis will be bulkier and more globular compared to the subacute variety, and they can cause ulceration or perforation of the underlying valve leaflets. Occasionally they can even erode into the myocardium and result in abscess formation. So what will be the microscopical features of these vegetations? Always remember that under the microscope we will see that these vegetations will consist of three zones. The outer layer or cap will contain fibrins and platelets, and they will appear as eosinophilic or pinkish. The zone beneath the outer layer or cap will be basophilic in appearance, and it will contain bacterial colonies. However, in treated cases, the bacterial colony may be lacking. And the deepermost zone will contain inflammatory cells. So there will be features of non-specific inflammation in the deeper zone of these vegetations. And always remember, when we are talking about the vegetations of subacute bacterial endocarditis, we will also see features of healing and repair as well. So now that we have talked about the morphology of infective endocarditis, now we will move on and talk about the clinical features of infective endocarditis. Now, the clinical features of infective endocarditis can be acute or subacute in nature, and overlapping of these clinical features may also occur. The clinical pattern of infective endocarditis is influenced by the causative microorganisms, the site of infection, previous antibiotic therapy, and presence of prosthetic heart valves. So all these factors can influence the clinical outcome of infective endocarditis. So what will be the clinical features of the subacute variety of infective endocarditis? Always remember, subacute infective endocarditis can be suspected when an individual with congenital heart disease or valvular heart disease complains of persistent fever, unusual lassitude or tiredness, night sweating, weight loss, flu-like symptoms, or when new signs of valve dysfunction are developing in that person. Other clinical features will include features of stroke, features related with arterial embolism, purpura, petechial hemorrhage in the skin and mucous membrane, splinter hemorrhage, Osler's node, etc. Now let's explain what do we mean by purpura, petechiae, splinters hemorrhage, and Osler's node now. So first let's talk about purpura and petechiae. Now always remember, purpura are red or purple colored spots that are seen on the skin, and they occur due to bleeding that is occurring underneath the skin. Now purpura, the size of purpura is between 3 to 10 millimeter, and petechiae are smaller bleeding spots, usually less than 3 millimeter in size. So this is in short about purpura and petechiae. Moving on to splinter hemorrhage. What do we mean by splinter hemorrhage? Always remember, these are tiny blood clots that are seen beneath the nails of the finger and toes, and they tend to run vertically. Now why will we see such splinter hemorrhage? They occur as a result or as a complication of embolism affecting the capillaries of the area. So now we will talk about Osler's node. So what do we mean by Osler's node? They are small, tender, subcutaneous nodules that are seen in the pulp of the digit, and occasionally they can also be seen in more proximal parts of the finger as well, and they are happening as a result of vasculitis. And splenomegaly is also another clinical feature that we can see, particularly when infective endocarditis is happening as a result of Coxiella infection. Hepatosplenomegaly or enlargement of the spleen and liver can occur. And also digital clubbing is a late sign of infective endocarditis, and we have already talked about clubbing in the previous video of this series. So what will be the clinical features of acute infective endocarditis? It may present with rapidly developing and severe febrile illness, chills, weakness, along with prominent and changing heart murmurs and petechiae. Now note that although fever is one of the most common symptoms that we can see in this disease, in many cases the fever may be slight or even absent, particularly in older adult patients. And in those cases, the only clinical features may be that of non-specific fatigue, weight loss, and flu-like symptoms. Now, always remember that cardiac surgery is a predisposing factor for infective endocarditis, so post-operative infective endocarditis may be suspected if a patient who has undergone cardiac valve surgery or other surgery presents with unexplained fever. So now that we have talked about the clinical features of infective endocarditis, now we will move on and talk about the diagnosis of infective endocarditis. So first, we will talk about two important investigations that are crucial in diagnosing infective endocarditis, and then we will also talk about a very high-yield topic for your examination, and that is the Duke criteria for diagnosing infective endocarditis. Now always remember, blood culture and echocardiography are very important in diagnosing infective endocarditis. Blood culture and sensitivity test is crucial to identify the causative microorganism and also in selecting the proper antibiotic. 3 to 6 sets of culture should be taken before antibiotic therapy is started. Now, why should multiple samples be collected? The reason is, in most of the cases, bacteremia or the presence of bacteria in the blood is intermittent. That's why multiple samples should be taken. Now always remember, in 90% of the culture positive cases, bacteremia is detected in the first 2 specimens. Now a very strict aseptic procedure should be maintained during the collection process so that no contamination occurs in the sample. Collecting blood sample from different venipuncture sites may reduce the chance of contamination, and always remember, it is discouraged to take blood sample from an indwelling line, for example from an indwelling arterial catheter. Now why is this thing discouraged? It is discouraged due to the concern of contamination and due to catheter-related infection. Echocardiography is very important to detect the vegetations on the heart valves and also to follow their progress. And echocardiography can also be used to assess valve damage. So now that we have talked about the 2 important investigations that are very crucial in diagnosing infective endocarditis, now we will talk about the Duke's criteria for diagnosing infective endocarditis. Now these criteria were established in 1994 by Duke Endocarditis Service, and they were revised in 2000. In your textbook you will see that they are known as modified Duke criteria, and they are used to establish diagnosis of infective endocarditis. According to these criteria, the diagnosis of infective endocarditis can be definite, possible, or rejected. Now, when will we consider the diagnosis definite? We will consider the diagnosis definite when either one of these 2 pathological criteria are fulfilled, or when a combination of these clinical criteria are fulfilled. And the combination may include 2 major criteria, 2 major clinical criteria, or the combination may include 1 major plus 3 minor clinical criteria, or the combination may include 5 minor criteria, 5 minor clinical criteria. So whenever these combinations are fulfilled, that is the time when we will consider the diagnosis as definite. Now the examiners are also fond of asking the question that when will you consider the diagnosis of infective endocarditis as a possibility. So the diagnosis of infective endocarditis will be considered possible when the following combination of clinical criteria are fulfilled, and the combination may include one major plus one minor clinical criteria, or it may include three minor clinical criteria. So now let's talk about these criteria one by one. So first we will talk about the pathologic criteria, and the first criterion was demonstration of microorganism in the vegetation or in the embolus that was derived from those vegetations or in the intracardiac abscess, and these will be demonstrated either by culture or by histology. So that was the first criterion. The second criterion was histologic confirmation of active endocarditis that is occurring in the vegetations or in the intracardiac abscess. Moving on to the clinical criteria, first we can see that there are two types, major and minor clinical criteria. Among the major clinical criteria, the first one is positive blood culture. And in case of infective endocarditis, we will consider blood culture positive when typical causative microorganisms are found in at least two cultures, or when we are seeing persistently positive culture in case of uncommon microorganism. The second clinical criterion was echocardiographic identification of valve-related mass or implant-related mass or abscess, or whenever we are seeing partial separation of artificial valves. And the last major clinical criteria was new valvular regurgitation. Moving on to the minor clinical criteria, we can see that they will include predisposing heart lesion, intravenous drug use, fever, vascular lesions, immunological phenomena, microbiological evidence, and echocardiography findings. So let's talk about these things briefly. So we will mainly talk about these two, vascular lesion and immunological phenomena. So what will be the vascular lesions that we can see here? Now the vascular lesions may include arterial petechiae, splinter hemorrhage, emboli, septic infarct, mycotic aneurysm, intracranial hemorrhage, Janeway lesions, etc. Now, what do we mean by Janeway lesions? Always remember, these are non-tender, painless, small, erythematous, macular lesions that are seen in the palm and sole, and they tend to occur as a consequence of septic embolic events. Moving on to the immunological phenomena, examples will include glomerulonephritis that may happen due to deposition of antigen and antibody complex. Immunological phenomena will also include rheumatoid factor, Osler's node, Roth's spot. Now, we have already talked about Osler's node. So, what is Roth's spot or Roth spot? Always remember, these are oval retinal hemorrhage that will also have pale centers. So, that is Roth spot. So, now that we have talked about the Duke criteria, now we will move on to our last topic, and that was the management of this disease. Now, management of infective endocarditis is a multidisciplinary approach, cooperation between the physician, the microbiologist, the pathologist, and the surgeon is very important for the successful management of this disease. Now always remember, antibiotic therapy will have a very important role in the management of this disease, and the choice of antibiotics will be based on culture and sensitivity tests. Also remember that when the patient is very ill or when we are finding clear evidence of endocarditis, sometimes it may be needed to start antibiotic therapy before the culture and sensitivity report is provided. In those scenarios, combination therapy is given that will include one anti-staphylococcal antibiotic, for example, nafcillin or oxacillin, plus one anti-streptococcal antibiotic, for example, penicillin, and it will also contain gentamicin. So these type of antibiotic combination therapy may be started in those cases. However, as soon as we get the culture and sensitivity report, and as soon as we can identify the specific causative microorganism, the treatment or the drugs should be altered so that more specific therapy can be started. When the causative organism is identified as Streptococcus viridans, the drug of choice will be penicillin. So penicillin may be administered for about 4 weeks. If the patient is allergic to penicillin, ceftriaxone or vancomycin may be used instead for 4 weeks. If the causative organism is identified as Staphylococcus aureus, that is sensitive to methicillin, then we can use nafcillin for 4 to 6 weeks plus gentamicin for 5 days. And if the causative organism was methicillin resistant Staphylococcus aureus, then the drug of choice will be vancomycin for 4 to 6 weeks. If the causative organism is enterococcal infection, then the drug of choice will be penicillin plus gentamicin for 4 to 6 weeks. And if the individual is allergic to penicillin, then the drug of choice will be vancomycin plus gentamicin for 4 to 6 weeks. In many cases, cardiac surgery may also be required. For example, debridement of the infected material and replacement of the heart valves may be required, particularly in case of staphylococcal infection and when the infection is caused by certain fungi. So this concludes today's video on infective endocarditis. I hope this video was helpful, and for my students, I will also recommend you to go through your textbooks to know more information. Okay, so that's all for today. Until next time, take care and stay blessed. Thank you.